Okay, this is going to be an overview of Chapter 3, the historical overview of U.S. healthcare delivery. By the end of this lesson, I want you to name at least 3 characteristics of healthcare delivery in pre-industrial America, name the 4 periods of healthcare, explain at least one reason based on historical context national healthcare has failed in the United States so far, and I would like to say so far because maybe we'll be more successful in the years to come, and describe the difference between Medicare and Medicaid, and know the difference between those two. So the first thing right off is that with the 4 periods. We have pre-industrialized era between the mid-18th and the 19th century, post-industrial corporate era, late 19th century. Third is corporate era from 1970 and continues to the 20th century, and we're now in at the 4th healthcare reform, which is currently in its infancy. So medical services in pre-industrial America were very domestic in character, means that they were based on relationships. And medical procedures were primitive. They were primitive, they used primitive techniques, and in that nothing was really proven. They would have herbal remedies to using different tools, and we did not have health insurance. And it wasn't until about the 1870s that medical training was largely received through individual apprenticeships rather than going to a university. And this is an image of people gathered around a corpse, but even then it was based on one person assisting and helping out. And it wasn't only until economic necessity that American physicians began opening medical schools. There were only about 42 such schools in 1850. So the real majority of the medical profession was getting training from individuals. It was lacking scientific standards and rigor. And going with this with medical practice, it did not have its today's prestige. There was no rigorous course of study or clinical practice. Anyone, trained or untrained, could practice as a physician. So barberos who cut hair could do bloodletting, and there was intense competition. Medical procedures were primitive, and in that there was inhumane treatment of mental ill patients, and there was limited surgical techniques and technical expertise. So in some ways, surgeries could be mutilations, in the sense that people could just be doing things with no rhyme or reason. No practice that was followed. And so it was it varied very much from person to person. And you could read about Dr. Rush here and some of the mental health treatments that he did, and they sound very, very inhumane by today's standards. And in that time, though, he was trying to establish new methodologies, but you could read about them here more. This is an image of a person sitting in a chair with blindfolds on. He does things with vertigo and spinning people around. And you could read more about what he does in this hyperlink that I provide in the PowerPoint. Now, moving on with medical practice, the clergy were often combined with medical services and religious duties. Many physicians had a second occupation because, well, they couldn't do medical practice alone. And this is one I want to emphasize with this picture, is there was a strong spirit of self-reliance in rural America because they could not access physicians and medical services. And that's something that's still prevalent and existing today in the United States, is we still have a disparity between rural America and urban America and what services are out there. And there is still this undercurrent of self-reliance that exists in rural America. So when we look at medical services in pre-industrial America, we see that medical training and education were not grounded. That that we had primitive medical procedures. There was intense competitions. People really relied on family members. Fees were paid out of personal funds. Healthcare was delivered in a free market. There were very few hospitals. And when there were hospitals, they were they had poor sanitation, and there was unskilled staff. And so I'm going to talk to you a little bit about almshouse, about pest house, and dispensaries and asylums. So medical institutions were not the clean standards that we have today, obviously. They were, when you look back, you'll see that sanitation practices were not the norm. And poorhouses, almshouses, was the forerunner to modern hospitals and nursing homes. Almshouse or poorhouse. And so this is where people would go to get treated or to be in a nursing home. And they were often confined to the unwanted elements of society. Asylums was the forerunner to medical inpatient psychiatric facilities. So I have a picture of a mental health psychiatric facility, and then what came first was asylums. Pest houses were operated to isolate people with contagious diseases. So think pest houses, contagious diseases. And dispensaries were staffed by medical students or apprentices and established outpatient clinics to provide free care. And dispensaries, which are things that grew into clinics and hospitals that we see today. So let's see if you can mix and match. I'm going to say that you need to think pest house, almshouse, dispensary, asylum. Okay? So often staffed by medical students, this place provided drugs to patients. Write down what you think it is. Goal was to contain the spread of communicable diseases. Which one do you think that is? For patients with chronic untreatable mental illnesses. And then you can see the rest. Served people with cholera, smallpox, typhoid, and yellow fever. Served elderly, homeless, orphans, ill, and disabled. Residents were called inmates. Whew. Bleeding, forced vomiting, and hot and ice baths were used. And outpatient clinics to provide free care to those who could not pay. Okay, so you had a choice between dispensary, pest house, almshouse, asylum. So here are how they match up. Almshouse, E and F. Asylum, C and G. Pest house, B and D. And dispensaries, A and B. And you could practice on this PowerPoint. I think this is a really good quiz question. So what do we see now as we move into post-industrial America is we see urbanization. Ooh, I stumbled on that one. Basically, more urban areas, scientific discoveries and their applications in medicine. We see a big medical educational reform, and we see that we have more power and prestige of physicians. Organized medicine. Hospitals become true medical care institutions. We see a reform of mental health care, which, it needed it. And we have growth of private health insurance and the creation of Medicare and Medicaid. So big advancement of the medical profession. And we start to have the professional organizations like American Medical Association. And we start to have the discovery of public health practices that were put into place to increase health outcomes. These are the big game changers with anesthesia, hand washing, pasteurization, antiseptic surgery, advances in x-rays, and penicillin. And each of these people were the game changers in making their discoveries or implementing a new practice. I list them here. And this is another good test question. Knowing who was the father of germ theory of disease, who was the father of antiseptic surgery, the discovery of x-rays, who discovered the antibacterial properties of penicillin. Anesthesia. We can be very grateful for anesthesia. Because no way would I want to do surgery or visit my dentist without laughing gas or having some kind of backup when I need to have a root canal. Thank you. Thank you. Game changers. Then we have educational reform. And we start to see Harvard coming in with their medical school, Johns Hopkins with their medical school. And so then we also see the development of hospitals. And so you can see with we get urbanization, we get discoveries, we get medical reform, we get power and prestige of physicians. We then get organized medicine. We get hospitals to really get the care established. And then we get the creation of Medicare and Medicaid. So we see the development and how each advancement lays a foundation for the next layer of improvements. So we also had the reform of mental health care, which is big. And at the turn of the century, we had federal policy promote education and research in psychiatry, which we needed. And we had the development of drugs to treat. This was a major game changer. So in the 1960s, the concept of community mental health clinics came about, and we started to deinstitutionalize the mental health hospitals, meaning we started to disband the mental health hospitals. Another big thing that came across was workmen's compensation. As we laid the laws for workmen's compensation, which said that if someone was hurt, then we would help them with their insurance, we laid the foundation for the next step, which is the birth of Blue Cross, the birth of Blue Shield, and then we have employer-based health insurance, which started in World War II as part of preventing inflation. These laws went into effect in 1948 and 1954. So each thing layers on top of each other. So knowing where we've come and where we need to go, our history does provide context. And I talked a little bit about workman's comp because it really started talking about if you were hurt, then this was some insurance to help you with your health bills and with your medical expenses. It was a trial balloon for the idea of government-sponsored health insurance. Then I talked about the Blue Cross and the hospital plans. And one of the big things is that people face the loss of income from illness and debt. So imagine for those people who are not on healthcare insurance, they are really at risk of having medical bankruptcy. So for those millions who are not insured, this is a real risk. And then Justin Kimball began a hospital insurance plan for teachers, and it became the model for the Blue Cross plans across the county. Interesting. So we keep moving forward. We have the physician plan, we have Blue Shield, it keeps growing, and then Blue Cross and Blue Shield merge in 1974, and we start moving to corporations. In every state, we start to have more of a managed healthcare approach. Okay, I am going to now talk a little bit about national health insurance and some of the reasons why national health insurance has historically failed in the United States. And this answers one of the learning objectives of this lecture. This is in your book, Exhibit 3.5, a nice little bullet point list. Europe, national health care failed to get an early footing because of labor, unlike Europe, and political instability in the United States. So we had some political instability in the remember the Great Depression, and even before that, we started to have some political instability. We also started to decentralize American system. We pushed the more power over into the states, and we really focused in on giving the U.S. federal government little direct control over social policy. Although we did start to turn that in the 1960s and mid-60s, but that was one of the underlying frameworks. This is another one. The German social insurance system was denounced during World War I. So since this term socialized medicine was associated with Germans and the German social insurance system, it started to become synonymous with national health insurance. So people started thinking socialized medicine is national health insurance, which is not the case, because if you look at other plans and other countries, a national health insurance does not always mean socialized medicine. It can be a mixture of many different things. but that is one underlying current that came about. AMA, American Medical Association, came out against national healthcare initiatives in the beginning. And middle class Americans, when we had a larger middle class, we have a smaller one, but if we espouse beliefs and values that are consistent with capitalism, self-determination, and distrust of big government. And you've probably have heard that and some political taglines is this distrust of big government. And so if we have the government involved in health policy like we do with education, that wouldn't work. And the middle class Americans have been averse to high taxes to pay for the increased costs of national health care program. And I think with this bullet point, we could say that middle class is not just all middle class. We could always have low income, all socioeconomic classes here. But there's been an aversion to higher taxes. And I can say this sometimes when you talk about taxes, you'll see people immediately start to shut down as soon as you say the word tax. I'm involved with political campaigns and staying away from the word tax and saying the word bond instead, even though bond is a form of levying taxes. It's just showing up on your property tax. So interesting. That has been one of the underlying currents. So when you look at this, here's a visual for you, for those visual people out there. You'll see that we had this World War II anti-German sentiment, which really was towards the Germans were having a socialized medicine, and we associated that with national health insurance. FDR put some proposals out that were successful. Some of them were successful, but some of them were defeated by the AMA. Truman did this also, but it was shot down. And then the Clinton administration started to put out some healthcare reform items, and this was also shut down. But know that not everything was shut down. We did have Medicaid and Medicare. And before 1965, it was just private health insurance was widely available. But we started to shift to providing a program that would start helping our vulnerable populations, elderly, and people with certain health conditions. And so we had parts A and B, and then we had Medicaid, which is income criteria specific. So I like this chart. Medicare is on one side, Medicaid's on the other. If you look straight down Medicare, it really only has coverage for elderly persons, non-elderly disabled persons on Social Security, and non-elderly persons with end-stage renal disease. There's no income means test. There's no class distinction. There's Part A for hospitalization and short-term nursing stay. Short-term nursing stay. I stress short-term. Part B for physician and other outpatient services. And then there's Part C and D for managed care, and then D for prescription drugs. It's a nationally uniform federal program. It's funded from a Title A of the Social Security, and it's financed through payroll tax by employees, employers, and self-employed. Part B is subsidized through general taxes, and then Part C and D have some cost sharings. Look at Medicaid. Medicaid covers only the very poor, income criteria. It's associated with public welfare. All services are covered under one program. It varies state to state. And it's funded from Title 19 of the Social Security Act. And it's financed by states with matching funds from the federal government. And it's based on capitas per income. So you'll see some states actually put more money out with taxes and receive less federal money back. It has a lot to do with their per capita, how much money they can match. So when you see Medicaid and Medicare, they're distinctly different, but they're both programs that are there to help with health insurance. So anyway, I went over these bullet points, Medicaid and Medicare, how they differ. And I like this table right here on 3.6 in your book. So look at Medicare. Take a look at Medicare.gov, and it really dives into the different parts, Part A and B, Part C and D. You should know who is covered by Medicare and who is not covered by Medicare. Again, How I remember the difference is that you care for the elderly. Medicare cares for elderly 65 plus, those with renal failure, and some certain disabilities. So that is Medicare. But know that one of the big things is that as we move towards the healthcare reform and doing healthcare reforms, we do have some things in place. We do have Medicare and Medicaid. We do have some things that are helping us move through filling in the gaps with healthcare. Some of those include telemedicine, and those things have been helpful. They've been helpful in addressing some of the gaps. We do still have problems with staff immigration and having healthcare in certain areas. But there's an opportunity for us to really start sharing and using technology to address some of these issues. And now we move into the era of healthcare reform. And this is where we're at right now. It's in the infancy stage, where we have numerous new regulations are being made. The government's regulatory still is very bureaucratic, but is expanding. Some things are helping, and we are looking at various aspects of healthcare delivery. One of the big things that happened is we had the Affordable Care Act, and it's the most sweeping reform for Medicare and Medicaid. It was passed by the Democratic majority in Congress, but it triggered a lot of lawsuits, and Congress upheld the constitutionality of the law, but left the option of expanding Medicaid to each state. And when that happened, it changed the ability to provide coverage, and it raised the premiums, the cost. So in some ways, when we don't have everyone in healthcare and everyone in a plan, our costs go up. We need everybody in it. So that's something that when we look closer at the Affordable Health Care Act, we'll see that there's some gaps that happened when we couldn't do the plan across the whole entire United States. And know that that's in other countries, they mandate that everyone is in health care insurance because that's one way to control costs. So that went away with the Affordable Care Act, when some states were opted to stay and others did not. So that is one of the things, is that again it ruled that federal subsidies for the purchase of health insurance could not be restricted if a state did not establish its own exchange to sell health insurance. So it just changed the law, and with it changed the economic model. So know right now that we are still in healthcare reform flux. That we're looking into different insights on how to fix it. And right now, healthcare reform in 2017 was a big issue. And now, as we go into presidential elections, we look at the president's candidates, they are looking at those healthcare reforms. And when we look at this, I'd love for you to go out to this website. It's Kaiser. It's one of these. It's Kaiser Family. I think what's it called? I should know this. Home. They are specifically looking at Medicare, Medicaid, but specifically Medicare and the availability and the enrollment numbers going up, but also the different plans. Compare Medicare for All and the public plan proposals of the different candidates. And here's what they're doing right now. Does it mean health reform? What's happening in Congress? This is a great website to check on what's going on. And trust me, we will be coming to this website and having discussions and having you dive into this website further when we start looking at how to pay for healthcare. So this was a brief history of healthcare and where we've been over the decades. So in conclusion, let's look back to our learning objectives. Can you name at least 3 characteristics of healthcare delivery in pre-industrial America? Can you name the 4 periods of healthcare? We covered that, and it's at the top of this PowerPoint. Can you explain at least one reason based on historical context why healthcare has failed in the U.S.? And we went over that with the different starting in World War I and World War II, some of the undercurrents, and also even looking at a rural America and some of the undercurrents of even how the medical system was set up in the United States, and describe the difference between Medicare and Medicaid. I can tell you that some of these questions will be on our quiz 1, and definitely take the chapter reviews, read the chapter, and look over the PowerPoints. Let me know if you have any questions. Have a great day.